Okay, good morning to Dr. Fairuz, Dr. Rafeek and my colleagues. Sorry for the delay. I'm Adiba. I will be presenting about sepsis and septicemic shock. The objective of this CME is to understand the difference between bacteremia, sepsis, severe sepsis and septic shock, to understand how sepsis develops and to identify the most likely cause and the severity of sepsis based on the history and physical examination, to know the typical workup required for sepsis and to know the key principles of treatment. First of all, the introduction. Sepsis is a common emergency department presentation often associated with severe illness and mortality rates approaching up to 50%. Evidence shows that early recognition and treatment in severe cases can reduce mortality rates. So we continue to definitions of septicemia first. Septicemia is the presence of multiplying bacteria in the circulation. Next is SIRS, which is Systemic Inflammatory Response Syndrome, which defined as the presence of two or more of the following. First, the temperature should be more than 38 degree or less than 36 degree. For the less than 36 degree Celsius temperature, it is especially seen in the elderly or in neonates. Also tachycardia, which is more than 90 beats per minute. Tachypnea, heart rate of respiratory rate of more than 20 breaths per minute, or PCO2 of less than 32 in the ABG lah. Total white cell of more than 12, less than 4, or more than 10% of immature band of forms. Sepsis is SIRS occurring in the presence of infection. Severe sepsis, sepsis with evidence of organ hypoperfusion, for example hypoxemia, oliguria, lactic acidosis, and altered cerebral function. Septic shock, which is severe sepsis with hypotension in systolic BP of less than 90 or MAP of less than 60, despite given adequate resuscitation.
Okay, we go back to the definition sebelum ni. Patah balik. Okay. So just now the definition you show, okay, this is, it's not wrong to use this. Okay. This all this definition has been around since the 1990s. Okay, now if you want to follow the latest definition of sepsis, we follow the Surviving Sepsis Campaign guideline in 2016. Yang itu they give a different kind of definition. But you still can use your SIRS criteria as part of your screening tool, okay, to detect patients with sepsis. Okay, this all is part of your screening lah. You want to determine which patient yang you can consider having sepsis or not. Okay. Next, go to the next slide. Next. Okay, this one sepsis, severe sepsis, and also septic shock. Okay, then if you anyone have the time later on, you can read on the Surviving Sepsis Campaign punya definition lah. Okay, but this one also is not wrong. You still can follow this. Can follow this. Okay, we can continue.
Okay. Next is the QSOFA, which is defined as Quick Sequential Organ Failure Assessment. This QSOFA is used in ED to screen for how much the mortality rate in patient that presented with sepsis. The easiest way to remember the QSOFA score is using the mnemonic HAT, which comprise of hypotension, altered mental status, and also tachypnea. The hypotension is dia punya ni terbalik. The hypotension is the systolic BP less than 100, altered mental status is CCS less than 15, tachypnea is the heart rate of more than 22. So by scoring the QSOFA, which is 0 until 3, 0 to 1, it is a not so high risk patient, which means that the mortality rate is lower. 2 to 3 of score.
QSOFA ni bukan untuk determine mortality rate which patient yang kita nak kira quick SOFA?
A patient that have sepsis. that have
So bukan patient have sepsis, patient with infection. Any patient that has evidence of infection, you kira quick SOFA. You don't kira quick SOFA for patient trauma, you don't kira quick SOFA dekat triad. So quick SOFA is not bukan maksud bila saya cakap pasal triad, bukan triad di counter triage tu. Dia once patient dah triad ke yellow, green zone apa semua, for every patient that has infection or evidence of infection, kena kira quick SOFA. Okay. So tujuan kira quick SOFA ni bukan nak tahu mortality. Is for you to decide which patient yang nak kena masuk ICU. So bila you ada a bunch of patient with infection, patient yang high quick SOFA score ni, you pilih untuk masuk ICU. Nanti I think Dr. Rafeek will go into the argument why the new surviving sepsis guideline ada isu dekat negara membangun dan sebagainya lah. Dia bukan untuk mortality, dia untuk determine siapa yang nak masuk ICU.
Yeah, okay.
Okay.
So we have the SOFA score and the Q SOFA. SOFA score used in the ICU. So Q SOFA they develop as a quick assessment for frontliners emergency department. So this one, kalau kita guna pakai, a lot of our patients actually fall into high risk. Okay, if you really use it, a lot high risk. So that means that do all these patients need to go to ICU? It depends on the availability of the beds and where do you practice. Okay, because here we have limited ICU beds. Okay, let's say if you compare to the West, okay, in other more developed countries, maybe you have more availability of ICU beds. So this group of patients who fall under score 2 or 3 will be managed, the best to be managed in the ICU. Okay. So they have the mnemonic HAT. Okay. Yeah, HAT. So you can also use this together with your CERS just now, okay, as a screening, okay, for patients with sepsis. Okay, can continue.
Okay, betul. So this is the quick SOFA. This is the full SOFA score that has been used in ICU for those patient that admitted to ICU for sepsis lah. They use this symptom to know the progression of patients after given adequate management and everything lah. Next is the pathogenesis of how sepsis work. So in sepsis, the host immune response fails to control or overreacts to invasive pathogens, which will lead to two critical events. The first event is involve marked abnormalities in the inflammatory response in the host. The host response will vary from hyperinflammatory response in early stage of sepsis to a blunted inflammatory response in the later stage of sepsis, which then leads to an increased risk of secondary hospital-acquired infections. The blunted inflammatory response will result in programmed death of pre-immune epithelial and endothelial cells, which then leads to tissue injury and perpetuating the multi-organ dysfunction. For the second event, there will be an imbalance in procoagulant and anticoagulant functioning. In the most extreme situation, it will result in clinical syndrome of disseminated intravascular coagulation. This DIC will result in micro and microvascular clot formation, will cause impact in microvascular tissue perfusion and thrombosis of the small vessel, which then will lead to organ failure and the release of pro-inflammatory intracellular contents, which then further stimulates the innate immune response and perpetuates the underlying pathology. This is what I explained earlier. Next, where the common sites of infection can occur, mostly in the lungs, which comprise of 35%, and then next is the abdomen, 21%, the urinary tract, skin and soft tissue, and also other unknown sites. But in patients of more than 65 years old, the urinary tract is the most common source of infection. So what are the commonest pathogens that can occur, that can cause sepsis? Escherichia coli, Staphylococcus aureus and epidermidis, Streptococcus pneumonia, and also MRSA. which usually happen in patient with recent hospitalization or nursing home. Next is the clinical features of patient presented with sepsis. Patient in early sepsis will have tachycardia, tachypnea and fever. They can also complain of chills and rigor, which signifies the bacteremia. Patient can presented to us with confusion or other mental changes. Despite hypotension, patient's skin can still remain warm in the early sepsis. If the sepsis develop, the skin will become cold and clammy with increasing tachycardia, pallor and cyanosis. Patient will also have oliguria and hypotension, which is not responsive to fluid even after fluid intervention. So what are the investigations that we can do in patient presented to us with sepsis? First is to take the SBC lah, to see the total white count. The total white count can be low in overwhelming bacterial sepsis. And if patient have low platelet, we have to consider patient maybe go into the IBC already. Coagulation profile, especially in patient that presented that have purpura, prolonged oozing from the puncture site or bleeding from the surgical site or low platelet. This can also happen in the IBC patient. The glucose of sepsis, especially in patient with liver disease. You can take amylase if patient also have abdominal pain in their history. CRP, chest X-ray to see if there's infection like pneumonia. ABG or VBG, this is to see the lactate, because later we will have to do lactate clearance to help in prognosis, to know the prognosis value after we start management for the patient. Next is blood CNS, and this can include peripheral blood CNS, or if the patient already have IV line related sepsis, like patient that have IJV and can also take the blood CNS via the lines. And after we take the culture, we have to change the venous line and send culture from the tip of the line. Patient that came with UTI symptom, we have to take urine CNS and UFME. Patient that have abdominal pain, we have to do we can scan for abdomen to see if there's any abdominal collection. Cerebrospinal fluid, if we suspect patient to have meningitis. Joint aspiration if kita suspect ada septic arthritis. Blood film for malaria if patient came from malaria endemic area. And also ECG if patient if more than 60 years old or patient have known cardiac disease. After all the investigation taken, start to manage the patient we use the sepsis surviving campaign hour 1 bundle, which comprise of 5 points. First, to measure the lactate level. Second, take cultures before we start the antibiotic. Preferably we have to take actually 2 times peripheral blood cultures, and also depending on the patient's presentation, we have to take cultures on urine, sputum, and also cerebrospinal fluid, just like I said before lah. And also start antibiotics within the first hour or within 3 hours from triage. And then we have to start rapid administration of crystalloid of 30 ml per kg for patient that have hypotension or patient that have lactate level of more than 4. If after rapid fluid bolus, if the systolic BP still remains less than 90 or lactate still remains more than 4, we need to refer early to ICU for admission to ICU for further management in ICU lah. The fluid bolus, we have to aim MAP of more than 65, or urine output should be more than 0.5 cc per kg per hour. If the BP still does not respond to volume, we cannot delay to give a vasopressor lah.
Okay, so this 1 hour bundle, do you do it in all the patients with sepsis or otherwise? Semua patient kita kena ambil lactate tak? And then
Kena sebab nak buat yang lactate clearance.
clearance lah. Okay. Here, this is only a guide. It's only a guide. They say this is macam consider the macam best practice lah. It's not wajib you need to do. So whatever you want to give to the patient must be tailor-made to the patient. It depends on the patient. Anything you do, after that you must have reassessment. Okay, with regards to the lactate, you take one single value may not be really helpful. Okay, what we want to see is the lactate clearance. Okay, after you take the first lactate, by right after you resuscitate the patient, you give your fluids, you can repeat in 1 or 2 hours time. So you aim that you want the lactate to reduce lah, maybe about 10 or 20% reduction in your lactate. Okay, but you also must know there's a lot of other causes of the lactate to be high. So it's not only sepsis. Okay, sometimes if let's say you start the patient on vasopressor or inotropes, especially kalau you start patient on adrenaline, patient on adrenaline infusion can have lactate acidosis. The lactate value will be high. Another one is you give patient nebulized salbutamol. Salbutamol also is a known cause. It will increase your lactate. So is you have to know the other causes which can increase the value of the lactate. So tak semestinya hanya sepsis. Okay. Okay. Then with regards to your fluid, here they say they advocate 30 mils 30 mils per kilogram over a period of 3 hours. Okay, but this one, the evidence of this is actually weak. It's only a recommendation. Tapi kalau you tengok evidence dia, that the guideline give, they will put what is the level of evidence. So fluid ni is actually weak lah. Yang penting is you give adequate fluids, tailor-made to the patient. Assess the patient clinically. After you give each boluses, reassess to see whether patient need actually further fluids or not. Especially patient yang ada overload, patient yang ada CCF, nephrotic syndrome, patient with gross ascites. So some of these patients don't need maybe so much of fluid. Okay, you have to assess clinically. Use your ultrasound, check the IVC, buat bedside echo and also so on. Okay, BP. Why they aim MAP more than 65? Sebab apa? Any reason why we want the value they give 65? If you see in our plan each time, kalau kita tengok patient septic shock, we always put and we keep MAP more than 65. Why 65? Kalau ada yang your friends nak jawab pun boleh. Why 65? Okay lah, dia 65 MAP of 65 is the minimum the minimum requirement for the organ perfusion. So we know in a sepsis they get multi-organ failure. Okay, one because there is reduced perfusion, okay, hypoperfusion. So if you maintain at least 65, most of your organs will still be perfused. So kita aim 65. So after you give some fluids, then if your patient is not responding to fluids, then you have to start your vasopressor. Okay, one thing maybe that we actually a bit neglect, okay, that we don't see is that you must start your vasopressor actually early, not to delay. Don't delay your vasopressor. Because once the BP is dropped, BP start to crash, nanti patient develop multi-organ failure. It will be very hard to increase back the BP. So you start your fluids, then after some time, maybe within the first hour, and then you can start your vasopressor. Okay. And I think we can continue. Next.
Next is
volume. Okay. Here they mention regarding volume lah.
So to start volume resuscitation, first of course we have to give a large bore granula. So the initial 20 to 30 mg per kg cruciate bolus, which equivalent to 1 to 2 liter bolus normal saline or lactate ringus. Why lactate ringus? Because sometimes if we give too much of normal saline, it can cause hyperchloremic metabolic acidosis in large volume resus. That's why we can also switch to lactate ringus. So approximately for 70 kilogram adults, it is up till 2 liter bolus lah within the first hour. And after we give fluid resuscitation, we have to determine whether the patient is body responsive or not. We can see whether there's a rise in the systolic or the mean pressure, MAP, decrease in heart rate, improvement in peripheral pulses or extremity perfusion, and increase in urine output.
Yeah, okay. So in Malaysia, do we have ringers lactate? Ada tak?
Usually kalau kita bagi normal saline je tak tukar.
Nak tukar? Tak. Okay. What other solution yang same as lactate ringers? Ada? Okay, see.
Housemen.
Housemen, yeah, Housemen. You boleh bagi Housemen. Housemen is lactate ringers lah. Ha? Okay, see. Is quite safe. Generally, in a normal patient, you give 1 to 2 liters bolus of normal saline is generally safe. If more than 2 liters, then only you develop the risk of hyperchloremic acidosis. Too much of normal saline is not good. Huh? Okay, the word actually normal saline should not be there. Right? It's not really normal. Okay, you give too much of normal saline, risk of AKI. So generally 1 to 2 is okay. After that, you can assess. Okay. Kalau patient yang other options that you can use, you can give your Housemen. Sebab Housemen is considered macam balanced solution. Because if you see your serum osmolarity in your Housemen is almost the same as your body punya serum osmolarity. If you compare it to your normal saline. Okay. So what are the contents of Housemen? Dalam Housemen we have what? Besides your sodium, lagi apa lagi? Housemen. All this you have before lah. Okay, contents of normal saline, contents of Housemen, because you're giving it quite routinely. Housemen, you have a bit of potassium ada, kita ada calcium. We have a bit of your lactate in your Housemen. Okay. So then you have your chloride, you have your sodium. Okay, all this is in your Housemen. Next, continue.
Next is the vasopressor. The first choice for vasopressor is where patient fails to respond to IV fluid, like unable to achieve MAP of 65. First, we need to establish a central venous line, like neck line lah, to limit the extravasation or tissue necrosis. First choice for vasopressor is we use NORAD lah.
Okay. Why why no air is the first choice? Any reason?
Because in patient sepsis, patient have vasodilatation. In NORAD, they can give effect of vasoconstriction to increase the DPBP.
Yeah, because no adrenaline primarily acts at your alpha, kan? Your alpha receptors. So alpha receptors ni dia banyak ada kat blood vessel. So in sepsis you have general vasodilatation, you give your NOAD, nanti dia akan vasoconstrict. Okay. So this is your first line. First line is your NOAD. Okay, central venous. Do all patients need central line? Kena. As long as you can get a large bore granula, that will be good enough. You try to get a neckline, external jug or internal jug. If you're giving low dose for short periods, maybe 6 hours, like that, less than 12 hours, it's still permissible to give via the line at the antecubital fossa. Boleh lagi. The risk of extravasation dengan necrosis is more if the line is below the cubital fossa. Contohnya you pasang kat dorsum of your wrist, kan, kat your forearm, then you have a higher risk of necrosis dengan extravasation. Generally, if it's at your cubital fossa and above, risk tu is lower lah. Lower. Because sometimes it's very difficult to get a neckline. Kan? Then if you say, okay, no neckline, you tak boleh bagi your NOAD. So you tak start your NOAD, nanti BP will start to crash. You cannot achieve dia punya MAP. So worst come to worst, you have no choice. You can at least put a line at you can use the cubital fossa lah. Line kat cubital fossa. Okay, continue.
So next is lactate clearance. Tadi doktor dah explain.
Dah explain.
Uh,
Okay, never mind, can skip lah. It's explain lah. So I can skip.
Next is this is the most important lah, to treat the infection within 1 hour of recognition of severe sepsis or within 3 hours of triage. During delivering both, it is preferable to deliver both which is the hemodynamic stabilization and antimicrobial agents concurrently is ideal. Before we give antibiotic, we have to sample the organ infection lah, like peripheral blood cultures, like before I said lah. And then after we stabilize the patient, if the patient have any indwelling vascular line that we suspect that the cause of the sepsis, we need to drain or remove the lines lah.
Okay. Next.
This is the
Okay, habis lah. Okay lah. So for choice of antibiotics, you it's best you follow the recommended by the hospital itself. Some hospital dia akan keluarkan macam buku kan, antibiotik apa yang paling sesuai. Okay, or maybe it's regional. Belah north ni what are the common macam microbes. Okay, so antibiotic will be tailor-made lah. You can read books all that, but what practice in other countries may be different from here. Okay, so antibiotics have to be tailor-made. Okay, then you anyone who's interested, you can read on your Surviving Sepsis Campaign Guideline 2016. Okay, it has been I think the latest guideline have been updated November 2021. Ada some changes, then you can see on that lah what are the recommendation. Okay, but generally in patient with a sepsis, in summary is that you have to recognize. So if you fail to recognize patient in sepsis, then you delay your treatment. So recognize patient in sepsis, then treat the patient aggressively. Start your fluids early, but you want to give fluids must be tailor-made to the patient. Then don't delay your vasopressors. And then try to find the source of infection. Source of infection, start your antibiotics, your blood cells, and what you so forth. Okay. So ada soalan? Is there any more questions? So your topic is more to septic shock kan? If you want to read on sepsis, it's actually a very huge topic sepsis per se. So any questions? Kalau tak ada question, we proceed with the next presentation.
Okay.
Okay, Umi. Macam mana Umi?
Tak ada.
Okay lah. Okay. Kawan-kawan tak ada soalan lah? Nak tanya Umi? Kawan-kawan tak ada? Okay. Okay, Dr. Fairuz nak tambah apa-apa?
Okay, saya nak tambah sikit je. Pasal definition. So, tadi ada mention pasal SIRS kan. SIRS is Systemic Inflammatory Response Syndrome. Awal kan. So, first what you need to understand, Surviving Sepsis punya campaign punya guideline ni, dia dah ada 3 of 4 definition lah. I think the latest one macam Dr. Rafeek cakap, November 2021, dia ada update. The first one was in early 90s kot. Then the second one was in early 2000. And then subsequently the ones yang kita semua familiar lah. This is the third iteration of it lah. With some update at the end of last year. So the first Surviving Sepsis campaign punya guideline ni, that's when they come up with this SIRS ni lah. So basically they say sepsis is defined by these 4 criteria. The second one, they just expand on this lah. So dia lebih more detail and dia lagi banyak each organ apa semua. And because dia banyak sangat, semua orang lupakan lah yang second punya guideline tu. Semua orang macam tak ingat kan. Semua orang pretend macam it doesn't exist. So semua orang masih pakai yang SIRS ni lah. Okay, tapi by the third one, the definition of sepsis has changed. Because the previous guideline, they were trying to define infection. So basically what they say, bila ada SIRS, ada infection. And as you may yourself see, SIRS ni can be a bit misleading. Because if you kata patient ada SIRS akan ada infection, patient trauma pun ada infection lah, because your patient trauma ada tachycardia, tachypnea, and the total white might be high or might be low, because dia kan kena 2 or more kan. So
Two
issue
or
dia bila you
more.
pakai SIRS to define infection, you get people with runny nose pun sepsis, you get patient trauma pun sepsis. So it can be, it's not very specific. So by the third campaign guideline tu, dia cakap infection, dia tak define dah. Infection is bila ada bacteria or virus or whatever in a patient lah. So infection is infection lah. Okay, what they define is sepsis. The new definition ni is this, dia punya keyword adalah dysregulation of normal response to infection. So the third guideline ni cakap SIRS ni, temperature, tachycardia, tachypnea, high total white or low total white ni, is a normal response to infection. This is something that should happen. If you got an infection, tonsillitis ke pneumonia ke apa, this is your body's appropriate response to infection. Naik temperature, tachycardia dan sebagainya. Tapi if there's dysregulation of the normal response to infection, then it becomes sepsis. Sepsis ni is a dysregulation of the normal inflammatory response to infection. Maksudnya lepas infection tu dah settle, tapi your inflammatory marker masih very high, cause generalized vasodilatation dan sebagainya. So dia ada dysregulations, because everything in our body should be regulated. You ada infection, this is the response, and once infection settle, it regulates back lah, dia normal balik kan. Tapi bila ada dysregulation, dia respond je, dia continuous to respond makin teruk. Infection tu dah tak ada kadang-kadang. Then you end up having a problem because of ongoing inflammatory punya process. So itu kena faham this new guideline punya definition. Infection is infection. Tapi sepsis ni dysregulation of the normal inflammatory response. That's why dia orang tak define dah sepsis by SIRS. Dia cuma buat QSOFA tu. Is a screening punya tool to help you to decide which patient should be prioritized untuk masuk ICU. And this is one of the criticism of the third surviving sepsis punya campaign ni, because it's tailored for negara maju yang tak ada isu dengan ICU. Kan, kalau awak pergi kat red zone sekarang, awak kira quick sofa semua patient kat red zone tu, the likelihood is semua nak kena masuk ICU. Tapi kita ni, because of the limited ICU bed apa semua, kita tak boleh nak pakai fully lah. Tapi what we can use is, we can prioritize patient mana yang nak kena assess kerap sikit, nak kena tengok dengan lebih teliti dan sebagainya. Prioritize untuk masuk ICU tu susah lah, because lagi dengan zaman-zaman COVID ni kan, semua patient pun COVID kan. So lagilah patient yang sepsis yang biasa ni tak akan dapat priority untuk masuk ICU. Tapi because if you baca macam the surviving sepsis campaign ni, guideline yang ketiga ni, more than half of the recommendation is about ICU management. Ada ventilator setting, feeding, physio dan sebagainya, yang actually recommendation yang melibatkan emergency ni sikit je, probably 4 or 5, which basically your 1 hour bundle of sepsis tu lah. The rest manage kat ICU. Tapi I'm sure you've been in medical ward apa semua kan, yang intubate pun belum tentu masuk ICU, apatah lagi yang quick sofa 2 or more kan. So it's just an issue with our punya facilities lah, our resources. So you can take the concept, tapi nak follow strictly tu kena sesuaikan dengan local punya polisi lah. That's one of the main criticism lah about the third surviving sepsis campaign punya guideline ni, because nak suruh masuk ke ICU, tapi in the end ICU is a finite punya resource kan. So tu je, saya definition tu kena betul. Dia dysregulation of the normal inflammatory response. I mean, you can look it up lah, the actual wording dia tu. Tapi keyword dia adalah dysregulation of the inflammatory response. Infection is infection lah. That's why kalau nak kira quick SOFA, patient must have infection first. You bukan letak kat triage MA kat triage, patient ada quick SOFA, masuk red zone. Tak. Patient need to have infection first. You need to determine, okay, patient ni ada source of infection. Then you kira quick SOFA. To prioritize masuk ICU ke dan sebagainya. Dan bila masuk ICU, dia orang kira lah SOFA. Kan? Nak suruh kita hafal tu, tak lah kot. Itu sajalah sumbangan saya.